Warm welcome to each one of you as we gather today for the official launch of the Empowered for Life campaign. We come together under the theme Elevating Men's Health Through ED Awareness in Africa to unveil a campaign and spark a conversation long overdue, one that places men's health, dignity, and access at the heart of our public health agenda. An African proverb reminds us that the child who is not embraced by the village will burn it down to feel its warmth. This powerful adage captures the urgency of today's gathering. For far too long, millions of men have struggled in silence, burdened by stigma and overlooked by systems that failed to fully see or support them. Today, we begin to change that. It is through collaboration, shared learning, and bold leadership that we can address one of the most under-recognized public health issues of our time, erectile dysfunction. Not merely a clinical condition, ED is often an early warning sign of serious health concerns such as diabetes, heart disease, and depression. It is a signal we cannot afford to ignore. This webinar is more than just a campaign launch. It is actually a platform to listen, learn, and align around a shared purpose to empower men, educate communities, and transform systems so that care is safe, stigma-free, and accessible to all. Let me also take this chance to remind you that we are at a session that is being recorded and will be uploaded in due time on our social media handles. There will be opportunities for all of you to ask questions. All you will need to do is to click on the Q&A button and type in any question or comment or message that you might have for not just those who are here today, but those who will watch this video in the future. My name is Gilbert Manirakiza, and I am the Chief Executive Officer of the Newmark Group, a Pan-African strategic communications firm that exists to empower organizations to get the influence they need to achieve impact that can inspire the world. It is my great privilege to serve as your moderator today. Together with Viatris and our partners across Africa, we are proud to help steward this critical conversation, grounded in evidence, fueled by compassion, and driven by the belief that every single man deserves to live a healthy, empowered life. Now, let us dive into the core part of this conversation. We now turn the heart of our discussion to the panel of experts. These experts are leading efforts to improve men's health outcomes in Africa. They bring experience from public health, clinical care, community engagement, and advocacy. I'd like to welcome our panelists, each of whom will offer deep insights and a unique perspective on the topic of erectile dysfunction and men's health. Our panelists are the following. So we have Dr. Nnabugwu Ikenna Ifeanyi, Associate Professor of Surgery within the Department of Surgery at the College of Medicine, University of Nigeria. Welcome, Prof. Professor Shingai Mutambirwa, Head of the Urology Department, Sefako, Makgatho Health Sciences University in South Africa. Dr. Yusuf Ademola Haroun, Physician and founder, Love for Health Organization, Nigeria. And we also have Mr. Arvind Kanda, who is the head of India and Access Markets, ARVs, covering the regions of India, South Africa, and Sub-Saharan Africa at Viatris. Now that we know who is going to be having this conversation or leading this conversation with all of us today, allow me to get us started because I'm so excited to hear what our panelists have to say and also to see what you have to say. Now, erectile dysfunction is often misunderstood, with many men, many of us, viewing it as an inevitable part of aging or something to simply endure in silence. These misconceptions delay diagnosis and discourage health seeking. Dr. Nnabugwu, could you help us understand some of the most common myths surrounding ED and explain why early diagnosis and timely intervention are so important?
Okay, thank you very much, Gilbert. And thank you, Viatris, for this opportunity. It's a pleasure being in your midst. And I'm as excited as you are, Gilbert, that this is happening at this time. I want to seize this opportunity to welcome my co-panelists here and to also welcome participants in this webinar. It's good that it is happening. It is good that it is happening in our own time. Now, I am Ikenna Nnabugwu, like already introduced. My bid here is to talk to us, just stimulate us into understanding some things that will make us realize that some of the beliefs about erectile dysfunction and erection in general may not be facts. They may just be myths that have come along all these years. Now, we're going to use this outline. What does ED mean? It's defined, there's a consensus definition at this point that ED is inability to achieve or maintain an erection that is sufficient for satisfactory sexual performance. Now, this definition comes with some questions on some remarks. Whose perspective are we using? When does it become an issue? First time that the person is experiencing this, or sometime when it has happened a number of times? When does this person seek attention? Now, the other thing is, whose satisfaction are we looking at? The partner, the individual himself, or both? These are things that will always be explained whenever we are looking at erectile dysfunction. Now, satisfactory sexual performance will have to depend on a number of things. A number of factors contribute to the satisfaction after a sexual experience. The psyche of the individuals involved, level of libido prior to that sexual experience, the level of arousal, fantasies that had been before that experience and during that experience. It's also important to bring into picture the function of the brain of the individual. Beyond this, we'll then begin to look at the sensory inputs and the outputs pathway to the mechanism of erection itself, the instrument of erection itself, the penile tissues. All these will play a role in ensuring good erection and then a satisfactory sexual experience. There are types of erection based on what brings about the erection, the stimulus that brings about the erection. We have the reflexogenic erection, we have the psychogenic erection, and we have the nocturnal penile tumescence. In reflexogenic erection, there are some stimuli that have come into the individual, bringing about the erection. The stimulus could be visual, auditory, tactile, as the case may be. In psychogenic erection, it has to do with the individual's fantasies or psyche, bringing up an erectile experience. Now, nocturnal penile tumescence does not depend in any of this. The individual is asleep and unaware of the erection going on. Now, quickly, when we want to talk about erectile dysfunction, it is only one aspect of the various sexual anomalies that can occur in an individual. Now, erectile dysfunction can be psychogenic or it can be organic. Psychogenic is where the instrument of erection and everything about it is normal, but the psyche is responsible for the inability of the individual to achieve satisfactory erection. Organic is where there is something abnormal with the instrument of erection, which can be the vessels, can be the nerves, can be other factors, including medications and so on. We also recognize two other aspects to erectile dysfunction. Is it a situational event, something that has happened as a result of a situation that is going on? Or is it a persistent condition which has happened across all types of situations? It's important to identify these things. Now, if any person says ED is not common, that person is not really telling himself the truth. It is not low. The burden is not low. The prevalence is not low. The books will talk about up to 52, 58% prevalence, but we all know that many men wouldn't come out to talk about this problem. Even when they are prompt to talk about it, they don't come out. So the recorded prevalence is actually an understatement. And this is why a webinar like this is very important. Now, what are the risk factors to erectile dysfunction? The primary independent risk factor could be considered as age. While the intro was going on, it was mentioned that some people regard age as, erection should not be coming as we get older, and so it should be accepted. Well, we know that age is a recognized risk factor. But in addition to what age does, age also comes with other comorbidities that independently are risk factors. Atherosclerosis and others like that. Now, it is important to exclude this and to look for this while we are trying to attribute ED to the person's age. How do we assess for ED? It is surprising to know that many will not come up with the information. Many men will not seek attention from the right places when they experience ED. They rationalize it, they stay with it, they live with it, and they do not also recognize that living with it comes with a number of other problems, which they may disconnect from the ED, not realizing the ED is the reason for these other problems. Why does this happen? Culture and stigma come into play. Now, when we assess ED, we quickly try to, we use an instrument to objectively assess ED. And the IIEF5, the International Index of Erectile Function, the abridged version 5, comes into play. I won't want to bore us with the details of this, but those of us who assess men who will eventually come up to look for help when they are having erectile dysfunction will find out that we'll have to use this to categorize this men and then to monitor therapy. Now, where exactly does sexual activity belong? It's important for us to understand this. Sexual activity is an innate physiologic activity, just as feeding, sleeping, stooling, urinating, and so on. People don't learn these things Everybody is born with the ability to feed. It is not acquired. Everybody is born with the ability to sleep. It is not acquired. This is the same way every man is born with the ability to have sexual activity when the right time comes. It doesn't get acquired. What we acquire as we grow will be the things that modify this activity. And so it is important for people to begin to understand that when you discuss feeding, you discuss it freely. When you discuss sleeping, you discuss it freely. But when we discuss sexual activity, we tend not to discuss it freely, simply because of stigma and culture. I want us to understand that until we begin to discuss it freely, the way we discuss other physiological activities, it will be difficult for us to begin to correct ED promptly. What are the benefits of sexual activity? You see, most times the risks involved in sexual activity are highlighted. People tend to underplay the benefits. These benefits are seen in the short term and even in the long term. They are seen in the men involved, and they are also seen in their partners. Sexual activity, when it is satisfactory, mitigates against so many psychological issues that lays anxiety and relieves depression. Sexual activity maintains good sexual health. In other words, a good sexual activity now brings up a better sexual activity tomorrow. A bad one now endangers sexual activity tomorrow, creating the risk that it will also be bad, if not worse, tomorrow. So the earlier that cycle is cut off and re-energized or rerouted, the better. Good satisfactory sexual activity nurtures healthier relationships. It increases the tolerance for physical and mental stress. I've had someone who has told me that he performs better at office in his work after a satisfactory sexual activity. And this is not an isolated report. It will interest you to know that sexual activity improves immune function and can also be seen as a means of exercising. It helps improve sleep. It can also help reduce pain. I don't want to mention the pleasure because that is one thing that everybody knows about it. Now, these things are backed by studies. They are not just consensus statements. No, they are backed by studies. And I've tried to bring up one or two studies here. Migraine has been reported to, people have reported to receive remission, to obtain remission from migraine headaches with sexual activity. Now, there are a number of reasons why this happens scientifically. The endorphins, the prolactin, immunoglobulin A, immunoglobulin E, they are all known to be transiently increased. And the increase is also sustained over time when you compare people who are sexually active against people who are not sexually active. Again, this is scientifically proven. Cortisol is reduced, C-reactive protein is reduced. These are C-reactive protein we know is an index of inflammation. And so what it means is that sexual activity has the capacity to reduce inflammatory effects of inflammation on an individual. Sexual activity has been proven to improve longevity. It is not a myth, it is a fact. There are some misconceptions. We tend to believe that older persons are not interested in sex. So there's no reason to take a sexual history in this group of men and even women. That may not be true. In short, that is not true. Now, sexual activity is also misconceived as risky, especially for the elderly. It is risky because it can expose someone to unwanted pregnancies, exposed to infections, sexually transmitted infections, and in the situation where someone's heart is not functioning appropriately, can actually lead to death. Yes, we know this. But the important thing is that when appropriately utilized, sexual activity does not increase risk to life in any way. It's also believed, is a myth, a misconception, that it is quite irresponsible behavior to express or to discuss sexuality. That's really difficult to understand. But the culture, our culture, especially in Africa, tends to maintain this. You don't talk about it in the open. You don't discuss it at home. You rarely will have to get appropriate information in sexuality. Now, what does is that it gives room for people to assume and spread whatever they have assumed as if those things are correct and facts. So, it's important for all of us to understand this, that sexual activity is as fundamental as feeding. We all need good erection to have satisfactory sexual activity. It has its benefits, it has its risks. When the risks are managed appropriately, then the risks are reduced significantly. The benefits can only come from sexual activity and not necessarily from any other activity. Trying to indulge, for example, in alcohol or in drugs in a bid to satisfy some aspects of life that sexual activity would have satisfied results in calamity and bigger trouble. So for a number of reasons, erection diminishes with age. Yes, we understand that. But this has its consequences. And so as much as possible, there should be conscious efforts to pick it up, erectile dysfunction early, promptly, and then to do one or two things as we are going to hear as this webinar continues to be able to mitigate this condition. Thank you very much. I will leave us with this quote. It is better to live as a lion for one day rather than 100 years as a sheep. It is better to have a erection instead of managing dysfunction for a long period. Thank you very much.
Wow, thank you. Better to live as a lion for one day rather than a sheep for 100 years. That's a very interesting perspective to share. Now, I was very generous on time with you, Professor Nnabugwu, because you were setting the scene for this conversation and explaining why we are having this conversation. Why is it important to tackle this silent epidemic that Africa doesn't seem to be tackling? And you've done that very well. Thank you very much. Ladies and gentlemen, please give virtual claps to our first panelist for today. And over the next 10 minutes, maximum 10 minutes, I would like to come to you, Professor Mutambirwa. Professor Mutambirwa, having listened to what we've just heard from Professor Nnabugwu, I'm sure that you can agree that, first of all, ED is a common problem. It is probably much more common than many people think it is. However, many are unaware of the underlying causes that contribute to it. We've heard Professor Nnabugwu telling us about the types, and he went beyond that to tell us about the types of erection, types of challenges that we can have, but also the benefits of a healthy sexual life. And all this leads us to ask ourselves, what causes this? What should we be looking at in terms of prevention even? And also, there is this myth which has just been busted that it is merely a lifestyle issue, when in fact it may be linked to chronic conditions such as diabetes, hypertension, and hormonal imbalances. So, Prof, since it is not just a symptom of aging, could you help us explore the physiological causes and the key risk factors that increase the likelihood of erectile dysfunction?
Thanks a lot for the introduction, and thanks for Prof's presentation. It's really set the background for this, because I think one of the things that we must remember, erections are one of the most important things for many men, but we are also at a higher risk from death from various causes. Of the 14 leading causes of death, 15 leading causes, 14 of them happen more in men. And it's mainly this that leads us to have a lower life expectancy than females. And this pretty much sums it up. As guys, we don't take our health seriously. We think everything is just normal. You must wait for symptoms. Like Prof. Nnabugwu was saying, that most of the diseases that we have are not going to show any symptoms until it's far too late. And most of these are going to impact on your sexual health, including your erections. We've already gone through what this is, and the important part of this is that we must remember that it's about satisfactory sexual performance for the person and their partner, or the partner, because even having problems with your erections, and if you're masturbating or doing other things, it's still important for you to remember that your sexual health is important. Just to make it simple, a side view of the pelvic hair of a guy, most of the penis is made up of two sponge-like tissues, one on each side, called the corpora. And what happens when we get an erection is there's just a big flood of blood rushing into these corpora to give the erection. Now, to put it in perspective, if you go and exercise, you can increase the amount of blood flowing to your heart by about 3 to 5 times. For the erection, it's up to 120 times increased blood flow. And this brings us to the fact that this is actually, when you have a problem with erectile dysfunction, there are lots of underlying background problems, from diabetes, cardiovascular disease, psychological. All of these are going to be impacting on your erections and your sexual health and other areas. And I think I always like to bring the fact, Prof. Nnabugwu was saying that about the fact that these underlying organic problems are there, be it from low testosterone, diabetes, blood pressure, dyslipidemia, smoking. I'm not going to pontificate. It's the most important social choice you can make to prevent you having any disease. But all of these things are leading to oxidative stress. And I always like to tell my patients that it's not about sugar, it's not about fat, it's about damage to the endothelium, the inside skin coating of your blood vessels, which is going to cause constriction of your blood vessels, causing you to get heart attacks, strokes, loss of limb, and erectile dysfunction. And why is that so important? Because we know that if a patient has a persistent erectile dysfunction, that's at least 3 to 6 months of consistent erection problems, you are at up to an 11 times increased risk of getting a heart attack, stroke, loss of limb. Penile artery, slightly smaller than the heart, coronary, the heart, the one to the brain, the one to the leg. If you get an atheromatous plaque because of damage by oxidative stress, the first one to go is going to be your erections. So we have to recognize that it's not a Mickey Mouse condition. It's a disease which needs to be addressed. Keep in mind that we also do have other sexual problems as guys. We're relatively simple, only really 5, the big 5 of Africa. Libido, which is mainly based on testosterone, premature ejaculation, the commonest sexual problem that men get. 80% of guys get it at some stage in your life. And premature ejaculation is based on satisfaction again. If you are not satisfied with the time limit that you're having, you must get that checked. Ejaculatory problems, fertility issues, and erectile dysfunction, which is what we're discussing today, all more common in, theoretically, the elderly. But being older does not mean you shouldn't be having sex. There's data to show that if a guy over the age of 60 has sex twice a week instead of twice a month, barring all other comorbidities, they've got an increased longevity of 6 years. 6 years. It's huge. It's hugely important. But our biggest problem is that we don't address, so we know it's super common. At least 50% of men from 40 will have erectile dysfunction, but we don't manage it appropriately. But there are a couple of things we can start off with to help to prevent you getting to the point where you have problems with erections. And these are, again, the big five of Africa. Smoking, I'm not going to continue that again. Stress and depression. I don't think people understand how much stress is killing people. 80% of South Africans currently have some form of stress or depression. It causing endothelial damage as well, causing you to get erectile problems, heart attacks, strokes, loss of limb. Impossible. Physical inactivity, and this is not exercise. People don't like the idea of exercise. We want to talk about physical activity, which means even using the stairs instead of an elevator, walking to work rather than using a car. All of these will impact. You don't have to do too much to make massive impacts for your health. Diet, and again, it's not just the thing, it's the numbers of calories, but it's also the types of calories. Highly processed foods issues as well. Prof. Nnabugwu has already mentioned drug use and various other things. You have to be careful what you're using because you're going to have a problem. Once you've done those, we have to look at the therapies. What can we do? And we have to base this on levels of evidence. We want to have things which are structured and we know have got proof and safety. And we know that the first-line therapies for erectile dysfunction are the phosphodiesterase 5 inhibitors. These are the sildenafils, vardenafils, and tadalafils of the world. Low testosterone needs to be addressed because the PDE5s will only work if you have a correct level of testosterone. And then also injectables into the penis have level 1 evidence. How are the PDE1s working? PDE5s working? All they're doing is relaxing the smooth muscle, the endothelial muscles, to let blood flow into the penis. Not dangerous. In fact, there's all these anecdotal stories about people getting priapism from prolonged painful erections and having heart attacks and things from this are not true in isolation with the PDE5s. They're super safe, super effective, working for the 80 to 90% of our patients. What types do we have? We've got relatively short-acting ones like sildenafil and vardenafil, a relatively longer-acting tadalafil 20 milligram, which lasts for up to 3 days. And then you can also have daily dosing, which gives less stress to some of our patients so they don't feel like they're having performance problems. All of them work very well. All of them have their places. And we know that if we change from if your patient fails on one of these, if you switch to another one, often you can rescue these patients in 20% of the time. Do remember that hormones are involved, from testosterone, estrogens. Serotonin is there for desire, arousal, orgasm. All of these things are important and they have to be addressed as well, because if your hormonal profile is off, you can run into problems. Other levels of evidence, level 2, level 3, level 4, they're there. Combinations, using vacuum devices, they're also very important. I think the first step for the majority of patients, after you've done the big 5 of lifestyle changes, is to look at the PDE5s. Mixing up for level 5 evidence, there are lots of things out there, supplements over the counter, which have some evidence, but they're not level 1 evidence, as with the PDE5s, testosterone, and the injectables. And going forward, there are new things that are coming out. And I think we have to remember that this is an evolving field. Since '96, when sildenafil was first revealed, we've had multiple trials showing that men's health can be improved by improving erections and now the general sexual health problems. But all of these new things are also going to be balanced with the current medications that we're having, including the PDE5s. Keep in mind, as we end off, that the sexual problems of a partner will impact on the other partner as well. We know that it can, especially in heterosexual couples, can impact on arousal, libido, pain when during intercourse. All of this is super important. But one of the biggest problems is that we don't discuss it. Prof. Nnabugwu said so, that the biggest issue is our lack of communication. We have to start discussing it. We know that 70–80% of patients want to have a discussion about their sexuality, but only 5% of treating physicians actually do something about it. We need to make sure that we do it. How do we do it? Make it simple. Use the implicit model. Get some permission, give out limited information, some specific suggestions, including the big 5, and then intensive treatments, including the PDE5s, injectables, and testosterone. That, I'd like to thank you for your time, and I look forward to further discussion.
Now I want us to go into the next stage of this conversation, which is the emotional toll of erectile dysfunction, which can be profound. Even from what you are saying, we can trace linkages between erectile dysfunction and depression, for example. And some of the emotional impacts can be quite profound. It can impact confidence, relationships, and mental well-being. Yet, in many communities, men suffer in silence. How does ED affect men emotionally? And how can we create safe, supportive environments for honest conversations around men's sexual health?
Thank you very much, Gilbert, for this very important question on the emotional impact or effect on erectile dysfunction. So you can see the first slide I have here is showing an open dialogue. The first step is that a man who has a problem with erectile dysfunction, it's one of the commonest male condition or male disorder that can be diagnosed even by the individual, because you would know yourself if you are able to last long in bed while making love with your woman. And this is something which a doctor doesn't need to tell you, especially if you have been performing better before and it is reducing. Also, erectile dysfunction is relative to different people. Some people might last for several minutes, some might last for a shorter time, but it is relative depending on you and your partner. It is a silent struggle and it affects men's health. We're going to look at three aspects in this. The first is the erosion of confidence. Erectile dysfunction often leads to feelings of inadequacy, significantly diminishes a man's self-esteem and confidence. A man who cannot perform well or who cannot satisfy his woman sexually, it tends to have low self-esteem. And in Africa, most of the women who are accused of infidelity is as a result of their man unable to satisfy them. There are other factors, but this is it. So erectile dysfunction can also open doors to infidelity by the woman. Another aspect which the previous speakers have talked about is anxiety and depression. These are psychosomatic effects of erectile dysfunction, because when this man cannot last long in bed and satisfy his woman, he becomes depressed. There's persistent worry and frustration. This is associated with the ED, erectile dysfunction, and it can trigger or worsen the cases of anxiety and depression symptoms. So this kind of person can develop insomnia. It can develop even what we call mania. It can develop hyperactivity. It might even develop some other psychological features which reflect in his metabolic system. A person might develop hypertension, might develop obesity, might develop all of those symptoms which are physical because of these psychosomatic effects of erectile dysfunction. So the physical effects can affect the erectile dysfunction, and also erectile dysfunction can also result in some physical conditions which will worsen the body. Then the last one I'll talk about on this slide is the social withdrawal. Men who have this problem tend to isolate themselves. Instead of reaching out to a physician or a urologist or a medical practitioner, they tend to stay away. They are unable to discuss it because of the shame, because of the cultural value associated with it, and because of the stigma also. So many people who are associated with this effect don't tell anybody. It's really a big problem, and it's due to the fear of being prejudiced or fear of judgment. 40% of men at the age of 40 tend to have this problem. And even the statistics is higher than this, because many men that have this problem don't come out. I rarely see a man who comes to the clinic complaining of erectile dysfunction. He might come for other diseases like prostate enlargement, hypertension, urethral atresia, but they rarely come to the hospital and complain that they are having erectile dysfunction. They have this ego. So the relationship dynamics, when erectile dysfunction enters the bedroom, erectile dysfunction introduces significant strain on romantic relationships, and it impacts the intimacy. So it affects both the man and the woman. The woman tends to feel that she is unattractive or unappealing to the man. The man also tends to feel that maybe there's something wrong why he can't satisfy his woman. There's a misrepresentation. The partners may misrepresent it as lack of attraction, leading to misunderstandings. There's communication breakdown, and there's also shared burden. Both partners experience emotional distress, empathy, and joint problem. So this bedroom relationship can also even affect their social relationship and general well-being. So there are cultural barriers in seeking help. So societal pressures. So the masculinity norms, traditional ideas of masculinity. And when the man is having this problem, it tends to ask or question his masculinity. It makes erectile dysfunction feel like a personal failure on his side. And it may also affect his work. It affects also his activities. It affects everything he does, his studies, his education, his lifestyle, just because he has this basic problem. Also associated with stigma, as I said, and shame. There's deep-seated embarrassment which surrounds his sexual health. It prevents him from discussing it with his friends, the family, and even the doctor. Is unable to tell anyone. Some men are too ashamed of this embarrassment that they can't even discuss it with their woman, their wives, or who they are having a sexual relationship with, because they feel so embarrassed. And the woman also feels embarrassed because when she is about to climax and the man is not able to satisfy her, she also feels disappointed. So this is something that affects both the man and the woman. There is lack of awareness. Many men are unaware that erectile dysfunction is a common treatable medical condition, not something to endure silently. So many people don't know that this problem can be solved. Many people just think it is something which they have to manage for the rest of their life. So someone is asking from Ghana, is it okay to use aphrodisiacs? Well, by the side, I believe that the moderator is going to give room to respond to it. We're going to talk about this in future. So firstly, is you have to look at the underlying cause, as the physicians have talked. It's not just using any medication, because you don't know what is causing this medical condition. So you don't just treat the symptoms, you have to cure the disease itself and know what is causing it. So empowering men, you have to break the shame, the cycle. As men grow older, their performance also goes lower. And at the age of 70, about 70% of men suffer from this. Even more than this, these are just the ones that are. And the problem in Africa is that, particularly in Nigeria, West Africa, where I am, we don't have adequate records of statistics. Many people don't usually come with facts and figures. So we base our statistics usually on Western or on research from other parts of the world. So peer support groups, confidential forums allow men to share experiences. So I believe that this is a topic that has to be discussed because it affects many people. We have to realize that we are not alone and that many people are suffering from this problem, and it is a relative condition. Open family dialogue. We have to encourage honest conversations between the families, normalize sexual health, and reduce the feelings of isolation. So should talk about this, people should talk more about it, because this is a single factor that bonds a man and a woman in their relationship, which is unique to both of them, the sexual intimacy.
Indeed.
And I believe that it should be talked about more. Inclusive wellness programs, integrating sexual health discussions to broader men's health initiatives, make the topic less intimidating and more interesting and fascinating to talk about. So the healthcare has a role to play in this emotional support. The healthcare provides a pivotal role in fostering environmental condition, which is favorable for men to talk about erectile dysfunction. There must be active listening. The health professionals, we in the health field must show empathy. We must educate them, and we must provide a holistic approach to this condition. We must know what is really causing erectile dysfunction, and we shouldn't prejudice anyone. We shouldn't believe that, oh, maybe the person has contracted a disease, that's why he is unable to last long in bed. we shouldn't be biased, and we shouldn't also prejudice. We should make them feel comfortable. We should show empathy as well as sympathy to those who have it. And community-based approaches to normalizing erectile dysfunction conversations. There must be public awareness. There must be campaign, workplace wellness programs, and community health fairs. So in educational initiatives through media and local events, just as this webinar, we should have more of it where we educate people about the effects of erectile dysfunction and how we can treat it. There should also be provisions for offering resources and informing men on their sexual health on a broader scope, and also providing initiatives and solutions to it. And the last stage is the community health fairs, where we provide accessible information and screening in familiar community settings, which can break the barrier. So we must screen men. One other thing again, when a man is 40 and above, they should also go for male screening. There are basic things which we should also check as men. So these are things which could be underlying factors of dispose us to erectile dysfunction. Emotional condition is also very, very important in a relationship. If a man is not emotionally stable, he might also develop erectile dysfunction. So any man who has this condition should not be seen as a failure because he cannot last long in bed. Many men are saying that if you can satisfy a woman in bed, then that is when you are a man. If you cannot do that, you are not. So we should also know that there's a difference between erectile dysfunction, premature ejaculation, and infertility. So we should emphasize erectile dysfunction is a common, manageable health issue with various effective treatments which are available in our society and in the hospital. Now, the success stories, how open dialogue changes lives. Initial hesitation. John struggled. This is a good example. John struggled for years, fearing judgment and avoiding discussions about his erectile dysfunction. That was the first one. So the second step is that he sought help. Encouraged by a friend, he finally spoke to his doctor and joined a support group. The third step is that he improved his well-being through treatment and open communication. John regained confidence and intimacy. And the fourth one is that advocacy. Now John shares his story to inspire other men to seek help and break the silence. So moving forward, we have to build a support ecosystem for men, create an environment where men feel empowered to discuss their sexual health openly, continue promoting open dialogue, and we should stop blaming women for all our sexual problems. So men have erectile dysfunction and they even blame the woman, saying, you are the one who is not romantic in bed, you are the one who is lying like a log, you are the one who is this and that. We should stop shifting the blame or shifting the goalposts. As we should educate both men and women. Erectile dysfunction, it takes two to tango, so both of them have to be educated about it, support healthcare providers in offering empathic and comprehensive care, as I said, and advocate for policies that prioritize men's sexual health as part of overall well-being. So someone is saying, at what point should you seek help? You should seek help immediately. Once you see that you're not doing well and it's causing a problem between you and your partner, it's something you should seek help immediately so that you can get a solution and it is treated.
Yes, Dr. Haroun, we'll get to the questions, but thank you so much for that presentation. It is a reminder that this is indeed a multifaceted problem. So we've heard that myths lead to challenges with health-seeking behavior. But even with those who are willing to seek behavior, we still have misinformation or lack of awareness around the causes, and actually lack of awareness on the essence of this problem. Then you've just told us about the challenge of mental health, how this particular problem manifests in society, but you have also given us some solutions and approaches of a large scale. I mean, 52% from what we've heard today, 52% of men potentially being affected by this challenge. So it means that this has to be tackled by a multitude of partners. And one of the stakeholders that has to be involved is indeed the private sector. And that's where I want to bring in Mr. Arvind Kanda. Mr. Kanda, access to effective, affordable healthcare remains a major barrier, as we have just heard just now, for many men living with ED. And we know that organizations and companies like Viatris that have great experience, great skill, that are leaders in the science field in coming up with solutions and products that solve the problem, also have great expertise and great insight. And that's why today Viatris has brought us together to discuss this challenge. So Arvind, can you share how Viatris is helping to expand access to ED treatment and how this campaign fits into your broader mission to promote health equity?
Yeah, thank you, Gilbert, for raising a pertinent question. And first of all, thank you to all the panelists for sharing their knowledge and expertise and guiding the discussion so far on the ED education part. At Viatris, our mission is to empower people worldwide to live healthier at every stage of life. This means ensuring access to trusted, high-quality medicines and addressing gaps in health equity, especially in underserved communities. Men's health is a vital part of that community. We recognize that, of that commitment. We recognize that. We recognize that ED is not just a private issue, but a public health concern that reflects broader challenges in access, awareness, and early intervention. Our role is not just to provide solutions, but also to help shift how society understands and responds to these challenges. Our vision is to build a future where men feel safe to seek care, speak openly about their health, and receive treatment that is safe, affordable, and grounded in medical guidance. Education should be and will be at the heart of our long-term vision for health impact in Africa. Erectile dysfunction, ED, is one of the most common health challenges facing men. Yet, I think it remains one of the least discussed. As we have heard in today's discussion, ED is often a sign of underlying conditions like diabetes, cardiovascular disease, or mental health issues. By integrating men's sexual health into wider non-communicable disease strategies, NCD as we call it, we can contribute to more holistic, preventive, and sustainable health systems across Africa. I think true impact comes not only from treating symptoms, but from addressing root causes and strengthening the continuum of care. Again, achieving real challenge and transformation requires partnership. And we will work closely, and we're already working closely with healthcare professionals, pharmacists, NGOs, and other key stakeholders to reshape how men's health is addressed at every level. Through collaboration, we are able to amplify expert voices, improve training and resources for providers, and make accurate health information more accessible to the public. We also see an important role for the media and digital platforms in breaking the silence and shifting public perception. Together, we can challenge stigma, promote early diagnosis, and ensure men receive the support and care they need. Improving men's health in Africa is a shared responsibility. It requires cross-sector collaboration, long-term commitment, and the courage to change the conversation. Viatris is proud to support this shift by empowering communities, educating both patients and professionals, and working with our partners to drive long-term transformation. We look forward to continuing this journey with all of you. Thank you.
Thank you. Thank you so much, Mr. Kanda. And you have just reminded us that it will take all of us. It will take all the stakeholders. It will take the media. It will take government. It will take private sector. It will take community activists. It will take everyone mobilizing together, putting efforts together, resources together, expertise together to be able to overcome this challenge or to help Africa overcome this challenge. And indeed, there are many people, including those who are attending this session, who have been asking themselves how to tackle this challenge. I've been moderating virtual events for a long time. Rarely do you get 180 people to attend a webcast such as this. So it means that getting such a strong attendance for an event is testament to the interest that people have in this particular topic. And obviously, There must be many questions, and I can see some already in the chat room. The first one that came in was whether it is okay for men to use aphrodisiacs. And the second, and that was from IK News Ghana. The second one was from Aina Obafemi, where Aina is trying to find out what happens if the man can't get his penis up and it wasn't so before. And I think some of this was mentioned during the presentation as to what could cause the situation, but it would be good for one of our expert panelists to address this, just to recap on some of the things that we talked about earlier. So I would like now to open it up. Please, our dear panelists, I would invite you to take up one of the questions. I will not direct the questions to you, but I would like to encourage you to pick up any of the questions that you feel is relevant to your field.
I'll jump in quickly because I'll take the first question, then let my other panelists come on board as well. It's okay to use aphrodisiac. Remember, an aphrodisiac is actually making you want to have sex. And the drugs that we're talking about today, for example, the PDE5s, do not make you want to have sex. In fact, they only work when you feel sexually stimulated. So I would not say that whether it's right or wrong to use an aphrodisiac, but the point is that these drugs that we're talking about today are not aphrodisiacs anyway. So they're not making people have sex. They're just making sure that the guy will be able to have sex. And so that, yeah, I think that should cover that one. Maybe.
Thank you so much, Professor Mutambirwa. Professor Nnabugwu, would you like to take
Thank you.
the question from Isaac?
Thank you very much. Just before okay, he has presented it as if it's as if it creates problems. This is again what we are trying to communicate, that it is not a myth. You are not. It's not a taboo. It's not. You're not doing something wrong in going for drugs that will make erection better. No. I want to let us know that it has also been proven scientifically that in men with BPH who are experiencing ED, that continuous addition of low dose tadalafil, sildenafil, low dose into the alpha-1 selective blocker that you use for the medical treatment for Lutz BPH is acceptable. It gives better outcome. It gives better quality of life. So it's better to see these drugs as the way we take medications for headache or medications for flu. And what is important, like has been pointed out, is ensure that there are no medical conditions that will explain the ED. Because it will be like your ED has come as a symptom to let you know that you have a medical condition, and you're ignoring that medical condition to restart the engine that has been shut down to allow you have a safe life or a safe flight. So once the medical condition has been addressed or has been excluded, please go ahead and have an appropriate dose of the medication. It is good.
Thank you so much, Professor Nnabugwu. Dr. Haroun, do you want to take the third question?
Let me see. Is it at what point in your sexual life should you be hinted that you may be suffering for ED? Because sometimes you may not be able to have erection just because you are stressed. Erectile dysfunction is different from anxiety disorder or stress disorder. The best way you can diagnose erectile is by still seeing a physician or seeing a doctor. And you personally, you would know how you were performing before and how you are right now. So the point in which you would see a doctor is usually when you yourself as an individual notice a decline in your performance and your partner also notices this. So the best is to see a doctor or see a physician who would examine you, review you, and diagnose you of erectile dysfunction. So I'll give a classical example if time permits. There is a particular person who thought he had erectile dysfunction, and when he saw a doctor and he was reviewed, he found out that he is just having stress from work and his boss has given him more tasks to do. He doesn't sleep well. He has to meet up to the task, so he is unable to perform well with his wife. So once that was solved, he was doing well. Physician, a doctor who will diagnose you and treat you appropriately. Thank you very much.
Thank you. Thank you very much. And Mr. Kanda, let me come to you with a question from Enchel, who is asking, since healthcare is the responsibility of the government in most African countries, what are some of the insights or messages you could have for policymakers within ministries of health to be able to work with you and with all the stakeholders that you have outlined to get a proper solution to the challenge?
I think Viatris, we are already a leader, let's say, in antiretrovirals and infectious diseases. We know what it takes, to get to the government, to make them understand, the importance of this particular disease, and work with them, in terms of creating. There has to be an ecosystem that has to be created for erectile dysfunction. It has to be treated like any other disease. Antiretrovirals, for example, was AIDS, HIV and AIDS was a big, taboo area. People didn't want to talk about it. But today we have 25 million patients on treatment for this particular disease area. So I think we need to get somewhere there for men's health, and I think the important thing is to start the discussion, make people aware, make the governments aware, make them understand that this is a significant public health problem that needs to be solved, and then solving the problem is the easier part. I think just ensuring that the problem is heard, understood, and it reaches the right people who then will sit down together to solve it. I think that's the difficult part. I think that to take the number of patients in HIV from 1 million to 25 million took 20 years. So we need to start today.
Fantastic. Now, there are so many questions in the Q&A box, and I would love for us to cover all of them. But the truth is we don't have nearly as much time to go through all of them. So what I'm going to suggest to those who have asked questions is continue asking your questions, continue sending your comments. We'll collect them and we'll share them with the panelists so that they can be able to give answers, and we'll send those answers to you, our dear participants, because we appreciate the fact that this is an important conversation. It's been too long in the waiting. It should have happened before, and the fact that we are having it, that's why we have so many questions and insights and perspectives. And now I would like us to go into the unveiling of the Empowered for Life awareness program, or awareness campaign, if I can put it that way. And for that, I would like to invite you, Mr. Kanda, to lead us into this official unveiling of the Empowered for Life campaign, which is a bold initiative that is transforming how we talk about, how we treat, and how we support men's health across Africa. Mr. Kanda, please do
Thank
the
you.
honors.
Thank you, Gilbert. Thank you to our esteemed panelists and to all of you who have joined us today. As we've heard throughout today's discussion, ED, erectile dysfunction, is a significant public health concern. That's why today I'm proud to officially unveil EmpowerED for Life, a Viatris-led initiative that places men's health at the heart of the healthcare conversation in Africa. This campaign is about awareness, empowerment, education, and access. Our mission is simple: to educate men and communities about the science and implications of ED, to destigmatize conversations around sexual health, to encourage early intervention and diagnosis of early underlying conditions like diabetes, cardiovascular disease, and mental health issues, to ensure that safe, affordable, and effective treatments are accessible to those who need it. At Viatris, we believe that access is the foundation to better health. Our mission is to empower people to live healthier lives at every stage. We deliver on this promise through our three key pillars: access, leadership, and partnership. With operations reaching nearly 1 billion patients annually in over 165 countries, we live by the belief that everywhere health matters. But meaningful access doesn't just begin in clinics or pharmacies. It starts with awareness and with honest, open conversations like the ones we're having today. Erectile dysfunction is one of the most common, yet least talked about men's health challenges. It affects confidence, relationships, and emotional well-being, but it does not have to be hidden. To every man listening, you are not alone. Help is available, and you deserve to speak up, be heard, and be supported. On behalf of Viatris, I hereby declare EmpowerED for Life officially launched. May this initiative be a catalyst for open dialogue, stronger systems, and healthier lives for men across the continent. Thank you.
Thank you very much, Mr. Kanda. And now we're going to watch a quick video that gives a sense of what the campaign is all about. This launch of the Empowered for Life campaign marks more than the start of an initiative. It is, Mr. Kanda have just remarked, it is signifying the beginning of a movement to break the silence, to challenge the stigma, and to bring men's health into the center of our conversations and care. Together we can build a future where men feel informed, confident, and supported in managing their health. We invite you to join us. Share the message. Start the conversation. Be a voice for change. And help us. Help this campaign. Help the Empowered for Life campaign achieve its goals. And as we close this session, one message is very clear: men's health must no longer be left in the shadows. Let us remember, ED is not just a condition, it is a signal that deeper conversations are needed, that better access is urgent, and that every man deserves the dignity of understanding, support, and treatment. A big thank you to you all, and we hope to see you in this collective commitment to talk openly, to act early, and to stand together. Thank you very much, everyone. And you may clap for yourselves as we close our activity for today.